Welcome to Take Charge. We are here today at the Army and Navy Club. My name is Ingrid Paris Hicklin. I am the host and producer of Take Charge, the show. And we are here because we're attending the Red Dress event. This event is dedicated to taking care of your heart. So you'll be listening to phenomenal physicians who will give you advice and pointers about how you need to take care of your heart. So stay right there and get ready for some powerful information.
I'm Laverne Chapman. I'm a member of the Arlington chapter, and we welcome you and just know you're in for a wonderful, wonderful afternoon. Our MC for the evening is Allison Seymour. Let's give her a big hand.
Thank you, thank you. How's everybody? Good evening. How are you? You all look so beautiful from where I am. You really do. Now, just let me get this out the way. As a Delta, I did have a closet full of red dresses. So I'm halfway there already. I'm so happy to be here this evening. I would like to thank the Arlington, Virginia chapter of the Mighty Lynx Incorporated for having me out. When my classmate, Michelle, asked if I would be interested in coming out, it was a yes, not just because of the fact that we've known each other since we were teenagers at Hampton, but because I truly, pirates stand up, but okay. Don't let me start something in here. We're here for heart health, not for Delta, not for Hampton. But we are, you know what though? We are here for African American women. And I stand here as a mother and a sister and a daughter and a wife and someone who needs to understand how much at risk I truly am. And a mother of 3 daughters, I want to be so educated so that this disease does not take me or my children or any of these beautiful faces I see one day earlier than they are supposed to go. So this event is just one of empowerment, and I just feel excited about being here and excited about speaking and meeting the physicians that we have up here this evening. So thank you, thank you, thank you. I was given some statistics about heart disease and heart health facts, especially for African American women. I just want to read three of them, that's all. 1 in 4 women will die of heart disease, but just like how black women have to do everything bigger and badder and better, it takes us more than it takes other races. So let me just say heart disease is more prevalent among African American women than our white sisters. Cardiovascular disease will kill nearly 50,000 African American women every year, right? That's somebody's daughter. That's somebody's wife, somebody's sister, somebody's partner, somebody's mama. So an event like this is everything. I'd like to right now ask Dr. Nicholette Martin, who is the chair of this year's Red Dress Committee for the Arlington, Virginia chapter of the Lynx, to please come to the microphone to deliver the welcome.
Thank you very much, Soror. And good evening, everyone. Thank you so much for returning, and those of you who are new, thank you for coming. This is the 8th annual Red Dress event, sponsored by the Arlington chapter in concert with this year 10 other chapters from the DMV. We'll keep going with the program, ladies. Again, thank you so much, and enjoy your evening.
All right, now I'd like to continue with the program and ask that Mary Clark, who is the chair of the National Heart Links to Heart Health of Reston, Virginia's chapter, to please come to introduce the national officer.
It is my distinct honor and pleasure to introduce a very talented, strong, and prepared leader of the Lynx Incorporated, Dr. Kimberly Jeffries Leonard. I know we can't do that together.
Well, I guess you all can see why this event is very close to my heart, no pun intended. This is really a very special night to me because, as Mary said, this is an area that has been so special. When we were able to start the HeartLinks program and work with NHLBI and the University of California, Davis, it really allowed us to put an issue on the map for the links that we really hadn't focused on. And to be able to institutionalize it in a signature program prior to my going out of office as the National Trends and Services Chair was really one of the biggest accomplishments of my Links career. And so to be able to watch this event grow and grow and grow to where it is tonight, I just want to congratulate all of our chapters. I want to congratulate our chair, Dr. Nikki Martin, and the members of the committee. This is phenomenal. So ladies, congratulations. So I leave you with the thought that this is our legacy. This is our prescription for the future. And if we don't do it, no one will be here to do it. So I appreciate you all coming out tonight. I appreciate you embracing our red dress event because this is the one day I look forward to putting on a red dress. And we all look good in it. Thank you.
But let me tell you about Dr. Cynthia Crawford-Green. Cynthia Crawford-Green is from Durham, North Carolina. She's a graduate of Hillside High School. Now that's important because from Hillside High, she would travel 8 miles to the University of North Carolina at Chapel Hill, where she was in the vanguard of African American students and became the first woman of color to earn a Bachelor's of Science degree in zoology. After graduation, she again traveled far from home. This time she went a block down the street to UNC School of Medicine. Now, postgraduate training in internal medicine included stops at St. Louis University and Georgetown University in the Washington VA program. Now, the last stop was as the medical staff fellow at the National Institutes of Health in the cardiology branch of the National Heart, Lung, and Blood Institute in Bethesda, Maryland.
I want to take a few minutes to try to talk to you about a whole body of work in cardiology. So by the time we finish here, you guys will know all there is to know about cardiology. Heart disease awareness in the African American population, and certainly in the face of all of these lovely. Okay, can you hear me now? Okay, so we like to focus on heart disease awareness in the African American population, and certainly with all of the lovely ladies here, we'd like to have some particular emphasis on the disease in women. Now, I am a clinical cardiologist, and it is my job to try to keep you from these lovely ladies when there is further progression of your coronary disease. Now, when we talk about heart disease, we're going to talk a lot about coronary artery disease, but we also have hypertension, we have cardiomyopathy, and we're going to try to tie all of that in within the next 6 minutes. Risk factors for coronary artery disease. Well, what are those? Well, that means that if you have either of these, then you have an increased risk for the development of blockages in the blood vessels to your heart, also known as your coronary arteries. The schematic there shows what a normal blood vessel with just some minimal plaquing. And I heard the young lady say that we would like to prevent heart disease, and that's a tall order, because if we go and look at blood vessels, even in infants, we can find some intimal plaquing, even as infants. So it is our job to do everything we can, if we can't prevent it, certainly to slow the progression of the disease. A heart attack is when you have significant plaquing, as you see in the furthest coronary artery, which impedes the flow. The heart muscle doesn't get enough an adequate blood supply. It doesn't get enough oxygen, and then that's when you do the Fred Sanford and grab your chest because it's all hurting. Now, What are the risk factors for developing blockages in the blood vessels in your heart? Well, we're going to talk a little bit about some of those things that we can do something about. That's diabetes mellitus, hyperlipidemia or high cholesterol, hypertension, smoking, and unfortunately, as we know, we can't do a thing in the world about our family. But you're certainly at increased risk for developing blockages in the blood vessels in your heart if you have a first-degree relative who has had a myocardial infarction prior to the age of 50. Diabetes mellitus is extremely common among us, women of color. The treatment goal is to have a hemoglobin A1C of less than 7%. I'm sure there are some of you in here who have diabetes. By a show of hands, how many diabetics do we have in here today? Okay, everybody not quite telling the truth, but that's all right. Okay. Certainly there is a familial predisposition for the development of diabetes. But does anyone know, for those of us who would have type 2 diabetes as opposed to the juvenile diabetes, which represents the absolute lack of insulin, does anybody know what is the risk factor for ladies of color for the development of diabetes? Weight. Absolutely. It is weight. There are some studies that suggest greater than 55% of African American women do have glucose intolerance or diabetes. Hyperlipidemia or high cholesterol is also associated with the development of those blockages in the blood vessels, which you noted in that initial cartoon on the first slide. The treatment goal is to have a total cholesterol less than 200 milligrams per deciliter, and an LDL, or the bad cholesterol, less than 100 milligrams. And if you've had an event, then we're going to try to drive that bad cholesterol down to 70. Now, some of the people in here who know me say that I'm trying to keep my business going because every year I have a infamous party that's called Chitlins and Champagne. And let me just tell you what's the first thing to go. It is the chitlins. Okay, elevated blood pressure or hypertension is also extremely common in those of us of color. The current treatment guidelines are to have a to start treatment with a blood pressure greater than 140/90. And once one is over 60, it is, the JNC8 is now suggesting 150. Now, high blood pressure is something that is near and dear to me because I would guess 80% of the patients who come to me with high blood pressure. And some of the symptoms that they present may be something that you guys have said. God, I am so tired of going to work. They just get on my nerves. As soon as I get to work, I get this headache. I tell you, my sinuses. Oh, girl, I can't get rid of these sinuses. That's what's causing me to have this headache. And then they come into the office, and of course, that blood pressure is 180/110. And many times, patients will say to us, I never knew I felt so bad until now I feel so good. We are told that hypertension is a silent killer. But I stand before you, ladies, tonight to say it's not silent. We just choose not to listen to it. Okay? I want to talk a little bit about what can we do to, as our role as mothers, wives, as well as patients. And I want to give you 3 brief clinical vignettes which point out some of the difficulties in the treatment of heart disease in African Americans. And I actually chose patients who came this week to make it even just how how much heart disease we do see. AT is a 17-year-old high school senior who was sent to me for a blood pressure of 150/90 by his pediatrician. He's a football player. He's a wrestler. Very active, very fit, but clearly with an elevated blood pressure. By the time he got to me, Dad had taken the bull by the horns, and he said, no more salt, no more Chinese carryout, no more Mickey D's. And when he came into the office to see me, which proves that this works, ladies, his blood pressure was 110/60. And that was merely with some dietary modification. So it is indeed possible, because I have a whole lot of people that come to me and say, girl, they can't nobody get my blood pressure down. Yes, we can. Yeah, we can. But it'll take a little work, not only from the pharmacy, but also by watching what we eat. We are very salt sensitive, as you know. And to speak to Black History Month, which also is February, this young man, and he was trying to ask me why did he have high blood pressure, and I asked him, well, do you know about the Middle Passage? And I'm so sad to say that this young man had never heard the word Middle Passage. So we have a lot to do in terms of teaching our young people about our history. Second patient also came into the office for the first time yesterday. She is a 45-year-old female educator who came in with literally a shopping bag of pills that she had taken over the years. She's had extensive medical evaluation, and her blood pressure yesterday, after coming from work where she teaches elementary school in Prince George's County, her blood pressure so her blood pressure was 250/140. Now, was she overweight? Yeah, well, she was a little bit heavy. Yeah, a little bit. Yeah, she did have some weight to lose. But over the years, when I left Chapel Hill and came to the real world, and I saw a patient like this, I immediately put him in the intensive care unit, put him on Nipride and all of that. And I sent her home yesterday. Because obviously this is of long-standing duration, and it is going to require extensive evaluation, weight loss, dietary modification, and exercise in order for her to get this blood pressure at an acceptable level. In our role as daughters, daughters-in-law, sisters, nieces, it's important also to realize that in part of caring for the African-American woman with heart disease, that you all have to be there when your older relatives do go to the doctor, when they are in the hospital, so that you can be their advocate. This patient, a 74-year-old, very active African-American female, was actually, she said, doing the Soul Train line in August at her birthday. When she came in to see me 4 weeks later, she was in a wheelchair. Unable to walk, having been to the 3 emergency rooms around our city, complaining of severe pain in her neck. This lady was not a drug seeker, because let's just be honest, ladies, it's very difficult to go in complaining of pain now and get pain meds, because all of us are just really afraid of drug-seeking patients. And it's very common that that's the way your grandmother, your aunt, even you, will be viewed by the people in the emergency room. So this lady went, and trust me, it doesn't matter how many degrees we have. That's just the reality. So when she came in to see me, I did an old-fashioned test. I just put the stethoscope on her chest and heard this wide open murmur. And this lady was actually a fascinoma. What she had was a rip-roaring case of endocarditis, which had radiated to her spine, full of infection. And a shout out to Dr. Jennifer Ellis here because she saved her life with a mitral valve replacement. But again, you have to be an advocate so that you tell that doctor, no, there's something wrong with grandma. I don't care what you say. 3 weeks ago, she was dancing. And today, she can't even walk? No, it's a problem. So we were able to help her. Now, the final patient that I want to talk to you about in terms of our role as mothers, as grandmothers, sisters, is to also tell that physician, no, there is definitely something wrong. This young lady had her baby, and a week later she said, oh my God, my chest is killing me. And she went to the emergency room. Oh, you know, it's that young mother thing. It was baby number 4, but still. And you'll be okay. But she went back to yet another emergency room where someone listened. And this young lady had a huge myocardial infarction, a huge heart attack, 1 week after having her baby. Okay? I wish I could tell you that this is the only patient in my practice where that has happened. But with women, when we talk about the different presentation, who in the world would think of a heart attack in someone with a newborn baby? Okay? So we do have to sometimes think outside of the box when we look at people who may not have all of those risk factors, who may not have that clinical presentation, but it is up to us to think, what could this be?
Now, Dr. Patsy McNeil is the attending emergency medicine physician at Shady Grove Adventist Medical Center and also the director of the patient experience with MEP Health. Born and educated in the Midwest, Dr. McNeil received 2 bachelor's degrees from Washington University in St. Louis, one in biology, the other in anthropology. This was in 1992. That's an interesting combination. She then went on to Vanderbilt University Medical School on a full scholarship to pursue her medical degree, which she received in 1996. Specialty training in emergency medicine was received at the oldest emergency medicine residency in the U.S. at the University of Cincinnati, where she went on to become a flight physician and chief resident of her class. After spending 6 years as an emergency medicine attending at Washington Hospital Center in Washington, D.C., she then joined MEP Health as an attending at, thankfully there's a doctor in the house. I don't know what happened to my voice. I know, this morning I was on TV talking for like 8 hours. But I'm happy to be here. She then joined MEP Health as an attending at Shady Grove Adventist Medical Center. She's gone on to be an equality partner in the company and now is the director again of the patient experience for the company's Mid-Atlantic division. Physicians Committee member of the Burrell Institute, member of the American Academy of Communication in Healthcare. Please welcome Dr. McNeil.
It's wonderful to be here. I do talks for my company up and down the Mid-Atlantic seaboard about a couple times a month. It's wonderful to be here to give a talk to a room of people who feel like home. So it's great to talk about cardiovascular health and stroke in the emergency department in particular. Now, before I launch fully into that, I'm going to take you back, way back, to give some context to what we're talking about tonight, and to show you that as far as we've come in medicine, in cardiovascular health, the more things change, the more things stay the same, actually. So, this is a sarcophagus. Didn't you go this far back, did you? This is a sarcophagus of Pharaoh Memepta, who was the son of Ramses the Great, the Ramses of Moses, right? So when you think about this, mummies, you think about ancient Egypt, you think about sand and pyramids. What you don't know is that the ancient Egyptians, they actually were one of the first, most sophisticated ideas of medicine in history. They were very far advanced. They were the first group who connected the pulse to actually the heartbeat, which is remarkable considering at that time in the world, most civilizations were still in caves. So I bring up the fact of mummies because when you look at mummies and they do studies on them, they are often riddled with arteriosclerosis or clogging of the arteries, right? So it's been around forever, this risk and this disease. And why might that be? People who were mummies were the wealthy. They ate a wealthy diet, which means they ate high fatty meats, salt-preserved foods, concentrated sugars, and bread. Sound familiar? Okay. They also were sitting on thrones, having people peel them grapes, right? And so they weren't exactly getting out and getting a whole bunch of exercise as well. These things are setups for being riddled with arterial disease, right? So let's go forward a little bit more, right? Oops. This African American surgeon in 1893 was the first physician in the emergency department in the United States, one of the first, to do open heart surgery, repair on a pericardium, okay? His name was Daniel Hale Williams, right? So that was in 1893. Let's go forward to 1903, the first EKG machine, about as big as a car, all right? Eindhoven invented that. So then we go forward once again to a gentleman named James Hendricks who characterized the first heart attack in a JAMA article in 1913. But we'd come even further than that. So that car-sized machine is now this big or even almost phone-sized at times, depending on where you go. So we have come further in medicine in the last 100 or so years than we came in the 5,000 years before that, right? But once again, remember that mummy. Remember his arteries full of plaque. More things change, the more things stay the same. So think about that. Diet, exercise. A lot of things we can do, but you can do a lot for yourself with simple diet and exercise. And I myself am tired of seeing people who look like me, who are often younger than me, who I have to send to my colleagues over here for a heart attack, okay? So in the emergency department, women come in and they have a multitude of symptoms, not always obvious for having a heart attack or being a heart attack. You've heard the statistics. 50,000 African American women last year died of heart disease. 1 in 3, if you include cardiac and stroke, will die a year, or die in general from these diseases. And that's more than all of the cancers combined, right? So this is something that you can do to help yourself, though. You can, once again, harken back to diet and exercise as far as controlling these things. So a woman will present, and we all know, perhaps, many of us know, the classic symptoms for heart disease that many men will come in with, right? Chest pain, radiating down the left arm, a little sweaty, a little nauseous. Not that difficult to say, I should get an EKG on this patient and see what's going on, right? But women will present, and their symptoms aren't exactly run-of-the-mill at times. They will have chest pain at times, but they will have often abdominal pain, pain in their neck or throat, pain in their jaw or face. Last year, I saw a woman who came to me, and the chief complaint on the computer was toothache, right? So I'm like, this is easy, get in and out, antibiotics, pain medicine, go to your dentist, exit to the left. But when she started talking, what she told me was, it's funny, for the last 2 weeks, every time I walk my dog, my tooth begins to hurt. And I just kind of forget about it and go home and goes away. Today, it won't go away. It just keeps hurting and keeps hurting, even though I'm not walking the dog anymore. EKG, acute MI. Much to my surprise, to the cath lab to get that fixed, right? So women need to be aware of themselves, be aware of things that are changing in you. It's difficult. You know, after a certain age, your risk goes up for heart disease. Once the estrogen goes away, you become postmenopausal, your risk for heart disease goes up. But be careful. Hot flashes are one thing. Hot flashes and fatigue and a little jaw pain are another. So you have to be aware of yourself and your health at all times, right? So, in the emergency department, what exactly is it that we do besides run around and do things emergently, right? You come in, your complaint is something that we think may be heart disease. We're going to draw some blood, we're going to do a chest x-ray, we're going to do an EKG, and we're going to figure it out. This is what we do. We want to make sure that your health is safe with us, right? It's not the commercial, don't I? But it's true. It's true. You want to make sure you're safe. And we do a risk assessment. Now, you've heard a lot about what the risk factors are for heart disease, right? So, uncontrolled or high blood pressure, high cholesterol, diabetes, obesity, if you smoke, these are all risks. But what we do is you come to the emergency department, we begin to do a risk assessment on you. Your story is part of it, but your health history and how you've allowed yourself to progress in health is a very big part of it. The scales, we weigh what your risk is. So if you're a smoker, one thing in the scale that's against you. If you're diabetic, one more thing. If you have a bad family history, one more thing. If you've got hypertension, it's one more thing. If you've got cholesterol, it's one more thing. So if you're a 45-year-old woman who has a complaint of chest pain, and you don't smoke, you exercise regularly, you have a good cholesterol, you have no hypertension, you don't have a family history, and you have the same story, the same EKG and labs of somebody whose scale is tipped in the wrong direction, you might get another set of blood work just to check and make sure the blood work is not progressing in the wrong direction. You're going to go home and you're going to see a cardiologist the next day. But if your scale is tipped in the wrong direction, you're coming in because you got risk. And even with the same story, the same EKG, and the same labs, you are at a higher risk of a bad outcome. And we don't take that kind of a chance on you, right? So, I was also told to briefly touch on stroke as well, because these illnesses run together. If you've had a heart attack, you have an increased risk of stroke. If you've had a stroke, you have an increased risk of a heart attack. So it's important to know both, hand in hand. Warning signs: weakness, numbness on one side of the body, right? Confusion, difficulty speaking, difficulty reading. They're also risks. Difficulty seeing, sometimes nausea as well, imbalance of the legs in addition to that. These are things that if you have them, come see me. Come see us, because you have about a 4.5-hour window before we can actually do something about these symptoms. There's a clot-busting drug out there called TPA that we can give. Sometimes it will open up that clot that's in the brain and help people's stroke symptoms go away. It doesn't always work, and there are risks with it, but it's something that we can do. So if you have symptoms like that, it's important not to wait till the next morning to see if they go away, which is a lot of the time we see, but to come in as immediately as possible. So I'm going to close off a little bit with preventive care, right? Avoid tobacco. If you've never smoked, fantastic. If you do smoke, stop. Do not start, of course, as well. Become more active. The recommendation is 30 minutes of brisk exercise, or brisk walking, dancing, 30 minutes 5 times a week. We spend 30 minutes on Facebook. We spend 30 minutes watching Big Bang Theory or whatever. Step on a treadmill, please. Walk around the park, okay? It's not hard to do. And when you're choosing what you're eating as well, right? It's called produce. Eat a lot of it. A little bit of meat, if any, a whole lot of produce, roughage, things that are going to be good and healthy for your heart. Make it a balanced meal, make it a colorful meal, make it a little bit of meat, if any, and make sure that you do things that can help minimize the risk that you have for heart disease. I would love for you to put me out of business, please, please. And I don't want to see you anymore. No offense. And I don't take offense when you don't want to see me. I'm the last type of doctor you want to see, and I don't take offense to that. So thank you.
Our last speaker that I want to introduce before we do our Q&A is Dr. Kelly Epps. She is the director for the Center for Women's Cardiovascular Health at Innova Heart and Vascular Institute. And I'm just going to be honest, there's a whole paragraph that I'm not going to read about you because I have no idea, but I know that you will. I'm serious. I want you to look in the program and forgive me for not trying to say some of these things. But I'm going to tell you some exciting things about Dr. Epps. Dr. Epps graduated with honors in biological sciences from Harvard University. She received her medical degree from Harvard Medical School and went on to complete her residency in internal medicine at Johns Hopkins. Following her residency, Dr. Epps completed fellowships in cardiology and interventional cardiology at the University of Pennsylvania. Dr. Epps currently is the director of the Center for Women's Cardiovascular Health, again at Innova Heart and Vascular Institute in Falls Church, Virginia. Having a special interest in women's cardiovascular health, Dr. Epps is passionate about educating women, who we're all here for tonight, educating women on their cardiovascular disease risk, early recognition, which is so important, of symptoms of cardiovascular disease, and prevention strategies. Now, during her time at the University of Pennsylvania, she earned a Master of Science degree in health policy. Of course, you are so busy, and you look like you see my daughter, and that upsets me. During her time, she earned a master's and degree in science, health policy, and completed a fellowship in cardiovascular health services research. Dr. Epps' research is focused on outcomes of quality of care for women with cardiovascular disease. She's presented her research at multiple national meetings and was a recipient of the American Heart Education Women in Cardiology Trainee Award for excellence in 2013. She is board certified in internal medicine, cardiovascular diseases, and interventional cardiology. She is originally from the Big Easy, New Orleans, and we have her though, she's married to one of our homeboys right in the DMV. So, Dr. Kelly Epps.
I'm an interventional cardiologist, so that means I spend about half of my time seeing patients in clinic and managing risk factors and trying to prevent them from developing advanced disease. And then I spend the other half of my time in the cardiac catheterization lab where we try to fix patients who have significant blockages and prevent them from having heart attacks down the line. And so I'm going to get started with so bear with me, some of these may not come correctly, but Mary is a 40-year-old woman, and she presented to the emergency department with chest pain and also with abdominal pain for about 1 hour. And she said that the symptoms were more like a burning sensation in the abdomen and in the chest, and she thought maybe it was related to reflux, which she had had in the past. However, she thought these symptoms were a little bit different and it concerned her enough that she thought she should come to the emergency department. She has a history of cardiovascular risk factors, including high blood pressure, high cholesterol, diabetes, and she also has lupus, which is a less of a known risk factor for cardiovascular disease, but it actually is. And she came to the emergency department to be evaluated, and her EKG actually reveals that she's having a heart attack. And I think that's one of the most important things that I can leave you with or start with is to get an EKG. I have a lot of women who have presented with symptoms that are concerning, and they've gone to see a provider or an urgent care, and the third time they come in, they said they haven't had an EKG, and that's one of the most important things that you can do. And so she was taken emergently to the cardiac catheterization lab. So cardiac catheterization is a procedure where we take pictures of the coronary arteries, which are the arteries that supply the heart with blood, and the purpose is to see if there are blockages that may be causing symptoms. And we use x-ray, and we use dye, and we thread wires and catheters up to the heart to diagnose coronary artery disease, but also to try to treat coronary artery disease. And so this is what we call an angiogram. So we took Mary to the cardiac catheterization lab, and this is us injecting dye into the artery, and she actually has a 100% blockage. This is one of her coronary arteries to the heart. And so we do a procedure, it's called balloon angioplasty, which many of you probably heard before. So there's a balloon that we inflate inside the artery, the narrowed part of the artery, to try to restore blood flow to the heart. And you can see here now, the blood flow has improved. But she still has a narrowing there in the artery. And that's when we move on to stenting procedures. So if you put a stent in, it helps keep that vessel open so that she continues to have good blood flow. And this is us deploying the stent in the artery. And then there's her final result. And so for Mary, I'll show pre and post again. So for Mary, she received a potentially life-saving procedure by recognizing her symptoms early, by coming into the emergency department, by having that EKG, and we like patients to have EKGs within 10 minutes of presenting to the emergency department. And she was able to come to the cardiac catheterization lab and have her artery opened. And she actually did quite well. She had minimal damage. She went home in a couple of days, had minimal damage to the heart because she came in early. And we have a saying, time is myocardium. Myocardium is heart muscle, that the longer you wait, the more heart muscle that will be damaged if you don't come in early enough to have the artery opened up. So what we know about interventional treatments in women is that women are less likely to be referred for these types of procedures. And part of that is that they may not be diagnosed, or they may be under-recognized that that's what their symptoms are about, that it's coronary artery disease. Also, women have higher complication rates than men, unfortunately, in part because our arteries are smaller, and sometimes it makes procedures more technically challenging. We have more bleeding than men, and some of this is because medications that we use in the cardiac catheterization lab to help thin blood were studied mostly in men, so we may not have the doses correctly for women. And then women are also more likely, especially young women, to have to undergo repeat procedures in the future. So actual failure of the intervention that we did, they may have to go back and have more stenting procedures or even coronary artery bypass surgery. But still, women do better if they do have this procedure than if they had no intervention at all. And so Mary was lucky, but we know not all women are that lucky. Heart disease is the #1 killer of women, and it claims more lives, we've heard this, but more lives than all cancers combined. And you can see here about 30% of women will die from cardiovascular disease. 1 in 30 American women dies of breast cancer, as opposed to 1 in 3 American women that die of cardiovascular disease. And a lot of women aren't aware of this. About 50% of women don't know that cardiovascular disease is the #1 killer of women, and only 1 in 5 women think that cardiovascular disease is their major health risk, their greatest health risk. And so 1 woman nearly every minute dies of cardiovascular disease. And we see here's a graph of mortality, and it's over time, over the past 3 decades, from heart disease. And every year since 1984, more women in the US have died from heart disease than men.
And if you can see where those lines cross, the blue line is men. You can see that's gradually or actually very rapidly gone down or decreased their mortality. That women actually started to go up and then began to come down, but that still our mortality is higher than men. Why is this? Part of it is that we didn't really recognize that cardiovascular disease was a woman's disease. We thought it was a man's disease. And so a lot of the research that went into curing cardiovascular disease, or I should say treating cardiovascular disease, a lot of the research was done in men. Healthcare providers didn't recognize that women were at risk, and we didn't realize ourselves that this was a risk. And we started to see, in about 2000, we start to see the decline in mortality for women. It lagged behind by a couple of decades, but you start to see the decline, and that is a lot in part due to awareness and education, the Go Red for Women efforts that the American Heart Association and Heart Truth by the NIH. So partly education, and also partly we have begun to do more sex-specific research on cardiovascular disease in women. So why do more women die? One, we're underdiagnosed, and that has to do with underrecognition of symptoms, which can delay care. Stress tests have decreased accuracy in women, in part because a lot of the stress tests were developed in men. Women sometimes have breast tissue, which can shadow the heart and may make the imaging of the heart more difficult. Women are undertreated, so we're less likely to get cardiac catheterization, the procedure that I showed you initially. Less likely to even get basic guideline recommended therapies like statins or cholesterol-lowering medicine, or medicines that can help the heart heal after heart attack, certain blood pressure medicines. And women are also understudied. So even today, women still only make up 20 to 30% of patients enrolled in all cardiovascular clinical trials. So the treatments that we are studying, we don't know if they work as well in women as they do in men. Or maybe there's some treatments that work better in women, but we don't know. We're not studying them. And we do know that women's hearts are different than men's hearts. They're biological differences. Women's arteries are smaller than men's. We tend to build up plaque in a more diffuse or spread out way across the artery rather than having these focal blockages that can really be picked up more easily on angiograms, the procedures where we take pictures of the heart. And there's this saying that men explode, women erode. And that has to do with biology, that men, their plaque tends to rupture, and it's something that's explosive, an explosive event, and that's why they have the crushing chest pain, the typical symptoms that we think of, whereas women's symptoms are more subtle, but their plaque slowly erodes. Some of them have the explosive types of heart attacks, but women are more likely to have ones where their plaque is just slowly eroding, and so they're having more subtle symptoms. So symptoms are, still most common symptom is chest pain in men and women, but women are more likely to have these subtle symptoms that I mentioned, things like unusual upper body pain, shortness of breath, fatigue, breaking out into cold sweats, lightheadedness or dizziness, nausea, and abdominal pain. And there's a study that looked at what are the symptoms of women who present with heart attacks, and actually chest pain was absent in 43% of women. Some of the most common symptoms were shortness of breath, weakness, and even fatigue. And women were more likely to have something called a prodrome, which means leading up to the heart attack for about a month, they were having these subtle symptoms: fatigue, sleep disturbances, shortness of breath, and anxiety. So early recognition of symptoms and understanding that some of these symptoms may be atypical in women, it's critical to recognize them. Women have worse outcomes in part due to the delay in care. And if they delay being diagnosed, they may be older in age, have more advanced disease, or they may be sicker by the time they're diagnosed. And so that makes treating them more difficult, and it may be in part explain why their outcomes are worse. So this is another patient of mine, Ellen. She complains of shortness of breath for about 6 to 12 months. She noticed it mostly when she was climbing stairs. And when she came in to see me in clinic, she actually apologized to me for being there. She didn't think she should be there. Her primary care doctor had urged her to go. And she blamed her symptoms on the fact that she had gained some weight recently, that she was deconditioned and didn't exercise regularly. But she didn't think it was her heart, and she apologized to me. She does have cardiovascular risk factors. She has high blood pressure, which is actually well controlled with medicine. She has high cholesterol, which was untreated, and that's important because women are or less likely to get cholesterol-lowering medicines. And she also was overweight. I ordered an echocardiogram for her, which is an ultrasound of the heart, and it showed she had normal heart function. Her heart valves were normal. And then I sent her for a stress test. And her stress test was actually abnormal. So stress tests are used to detect coronary artery disease, but it's not just any coronary artery disease. This is something that's important to understand. It's trying to detect more advanced or significant coronary artery disease, blockages that we think are causing an impairment in the blood flow to the heart. And so she did have a positive stress test, and so I referred her for cardiac catheterization. And so here's one of her arteries, the left anterior descending artery, and she has a blockage there. This one's a little bit more tricky to see. It's not 100% blocked, but she does have a blockage there. And so we proceeded with stenting of her lesion. And this is her artery after the stent. And so Ellen came back to see me, and 2 months later, she was actually doing quite well. She was surprised her shortness of breath had improved. Her cholesterol had improved. I started her on cholesterol-lowering medication. Her blood pressure was normal on medicines. She was practicing a low-carbohydrate diet, and she had enrolled in cardiac rehab. And cardiac rehab is something I just want to mention briefly because cardiac rehab saves lives. After I fix a blockage in the cath lab, that's not the end of what we need to do for women. And cardiac rehab is a program where women and men go after having heart attacks or stenting procedures or bypass surgery, where they work with a therapist who puts them on a treadmill, exercises with them, comes up with a plan to help increase their stamina while they're monitoring their EKG and their blood pressure, their vital signs. And they also get education on nutrition. So there's a 2/3 reduction in mortality in patients who complete 12 weeks of cardiac rehab. 80% of patients are not referred to cardiac rehab. So the thing that I think is striking about Mary is that she had significant cardiovascular risk factors, but she didn't recognize it. She didn't think she should be in a cardiologist office. And so we think about risk factors as non-modifiable risk factors. We talked about this a little bit earlier, but that's things that you can't change. But they put you at risk, but unfortunately you can't change them. That's age, sex, family history, race and ethnicity. And then there are modifiable risk factors like cholesterol, blood pressure, diabetes, physical inactivity, overweight conditions, and tobacco use. And we know that African American women, they are the group at highest risk for having heart disease of all major ethnic groups in the US. And in part because we tend to have a clustering of risk factors. We have higher rates of hypertension, higher rates of obesity, and higher rates of physical inactivity. And we also tend to be less aware of our cardiovascular disease risk factors. Also, as women age, their risk of cardiovascular disease increases. So women after menopause, they catch up to men in terms of how much the prevalence of cardiovascular disease, and then eventually they even exceed men in terms of the prevalence of cardiovascular disease. And menopause is not the cause, but we do know that there are certain risk factors that increase around the time of menopause, and that's bad cholesterol increases, good cholesterol decreases, blood pressure rises with age. And we see that about 10 years after menopause is where we see the increased risk of heart attacks in women. But heart disease is a progressive disease that happens over decades, and so being premenopausal doesn't protect you from cardiovascular disease. And in fact, we know young women have worse outcomes. The women who are younger who do develop disease tend to do worse. So death from coronary artery disease is decreasing in all demographics except women under the age of 55. It's actually increasing, we think in part due to a rise in the epidemic of diabetes and obesity. Physicians are less likely to talk to young women about their cardiovascular disease risk. And then young women are more likely to have delays in their hospital care, in part because providers may not recognize that they're at risk. And we think about traditional risk factors. Those are a lot of the ones that we spoke about already, like blood pressure and cholesterol. But there's also non-traditional risk factors that I like to talk to my patients about as well, because many times patients don't realize that having these diseases can put them at higher risk. So one is pregnancy complications. That's things like preeclampsia, pregnancy-induced hypertension, even preterm labor, gestational diabetes. Those all increase your risk in the next 10 to 15 years of having a heart event. And I have a patient who I saw recently who presented with a heart attack, and it was 10 years after she delivered. And she said she had gestational diabetes, she had hypertension, preeclampsia, she delivered early, and then she said, oh, but it all went away. In 3 months after I delivered, it all went away, and then she never saw a primary care doctor again. And so nobody was really following these risk factors, but she didn't know that put her at increased risk. And a lot of women don't know, but the American Heart Association considers these pregnancy complications as a failed stress test. Pregnancy can be stress on the body, and if you develop some of these complications, that should be a signal that you are at greater risk and a signal to make changes then, rather than waiting for the heart attack to be the signal that you need to make some lifestyle modifications. Early menopause is also a risk. History of radiation or even chemotherapy for breast cancers, autoimmune diseases like our first woman, Mary, who had lupus, depression, which tends to affect women more, increases your risk of cardiovascular disease, and so does stress and trauma. And so what is ideal cardiovascular health? The American Heart Association has specific criteria for what that is, and that is blood pressure less than 120/80, cholesterol less than 200, fasting blood glucose less than 100, no smoking, regular exercise, that's 30 to 45 minutes most days of the week just for maintenance of health. But if you're trying to lose weight, it's more, 60 to 90 minutes most days of the week. And then diet rich in fruits and vegetables. I know what you all are thinking, which is coming up next. So what percentage of women are actually in ideal cardiovascular health? There was a Women's Health Initiative study that looked at this, and unfortunately only 4% of women were in ideal cardiovascular health. And a lot of that has to do with physical inactivity. The good news is that we know that by maintaining ideal cardiovascular health, you can reduce your risk of heart disease by 80%. So there's so much that we can do. We just have to take action and take the initiative and do it. Good take-home points: that cardiovascular disease is the most prevalent and most deadly disease in women, and unfortunately affects African American women the most. Cardiovascular disease is preventable, and we can be our own best health advocates. I think that's by knowing your numbers, by recognizing symptoms, and by taking action. I just want to thank everyone for listening. Thank you to the Links chapters that invited us today, to the Red Dress Committee.
Thank you for watching Take Charge, the show that is striving to improve your health. Remember to follow us on Facebook, Twitter, and Instagram. And thank you so much for viewing this wonderful summit.